Good afternoon. Welcome to the Anesthesia Analgesia Health Services webinar. Welcome from California, and I welcome you wherever you are in the United States. Next slide, please. For those of you who have read the issue, and for those of you who had not had an opportunity, we obviously had a theme issue on health services research in March, published in March 17. We have reestablished this section of health services research, or I should say established by combining a number of other sections, because we felt that health services research is really a up-and-coming topic or subject or construct that we have not been invested enough in the perioperative space. And hence this new section in the journal, and hence the theme issue. Now, the theme issue had a number of very interesting articles covering a wide variety of topics, and we have chosen about 3 of them to be covered in today's webinar. Obviously, you see who I am. I am the executive director of the section on health services research and ANA, and also a Chances professor at the University of California, Irvine. Next slide, please. To join me in our presentation, I'm going to have Dr. Catherine Chen. Catherine is an associate editor in the section of health services research. And she is going to talk about the triple bottom line and stabilization wedges, a framework for perioperative stability. Obviously, a very important topic. I think she's going to give you, she's going to give you a framework of how the future will look like. I think this topic is becoming more important by the day. And as much as we talk about it, we did not have much progress on it. So hopefully with Catherine's help, we can see what progress we can make as individuals and society. Next slide, please. And we are going to close the presentation or the webinar with a very interesting presentation from Dr. Alaa Abd-Elsayed. And Alaa, first, I apologize if I butchered your name. I know how you feel. I don't have an American name either, so I apologize. But we are grateful for you for joining us. And Alaa is going to talk about the burden of COVID-19 cases. And he has led an investigation that looked into a statewide database from Wisconsin, as well as a narrative review of the literature. And I think it's going to be fascinating because sometimes we're focused only in the operating room. And in this case, we're going to be able to see a larger construct. Next slide, please. Just to make sure everybody knows, we are going to record it and it's going to be available later on. The structure is going to be 15 minutes for each speaker, to be followed by 15 minutes of questions. So anyone who has questions, please make sure you can chat them to us. Here you go, Q&A. Please use the Q&A button on the Zoom taskbar, and we will do our best to answer them. To clarify, I will do my presentation live, and then Catherine and Alaa will do their presentation. It's pre-recorded, but then they'll be available to answer any questions. So please just hold until you get to the end. With that in mind, I am going to start my presentation, my 15-minute presentation, and I am going to share my screen with you. The topic of my presentation is anesthesiologists and hospitalists in perioperative care, together we're stronger. There was a pro-con article in the theme issue that talked about the pro-con approach about preoperative visits, anesthesiologists versus hospitalists, but somehow that pro-con really moved to the area of perioperative care altogether and who is better. And as much as we try to make sure that the pro-con is not, I'm going to say, too strong, there were some parts of it that were quite interesting. We wrote an editorial in response to it. And so in the next few minutes, I will try and cover some thoughts from the editorial about this entire topic. For those of you who recognize this distinguished individual, this is, of course, General Stanley Mcchester. And he was the commander-in-chief of all the forces in Iraq in 2003. And for those of you thinking, why am I bringing 2003 and military into here? He became a famous because, well, one of his claims to fame is a New York Times #1 bestseller book, which is called Team of Themes. And in that book, he outlined a case study in which he showed that when he took over the forces in Iraq, those forces were really disjointed, did not talk to each other. Each force really reacted to its own challenges with its own resources, and sometimes in a contradictory manner. His first job then at 2003 was in essence to combine all the forces together to create a new structure, and in fact, create, as he calls it, the team of teams. It worked exceedingly well, and he became I'm going to say a father of a new conceptual framework that was very successful, what he did in the military and what he did later on. Now let's take that approach and let's move it to perioperative care. And perioperative care, on the left-hand side, you can see what today it is. It's fragmented care, it's discounted fee-for-service, it's payment for volume. And what the future should be, which really is collaborative care. And let's focus here. We'll talk about collaborative care and cooperative relations. We know that there is disjointed approach to the perioperative environment. There is nothing new about that. We, in fact, try to solve it with some models, such as the perioperative surgical home, which were some were successful and some were not. In the picture above, you actually can see a lunchtime at UC Irvine Health at 2015, where we talk about the design of the operating room or redesign. And of interest is that you can see here, that's me, that's the chief nurse, an orthopedic surgeon, a resident, a nurse, another nurse, and another nurse, essentially, CRNAs, blood bank, critical care. So we really try to get everybody together, but it's actually not that easy. We can talk about it as an ideal condition, but we'll see in the future that it's just not easy. Well, one of the reasons it's not easy to work together is because the perioperative environment is very complicated. And you can see from this figure, for one patient, how they need to go through evaluation, decision-making, surgery planning, nutrition, and all the way through. Within the context of our discussion, we're talking about hospitalists versus anesthesiologists, or I should say hospitalists and anesthesiologists. And so as we talk about the decision part and the pre-admission part, the question is, who is in charge of what? Who is best suited to do what? Who is interested to do what? And are we better off working together? I think that the elephant in the room, although there are 3 monkeys here, they don't hear, don't see, and don't talk, is the question is, how are we doing with perioperative care? And in fact, as you all know, perioperative care within the operating room at some groups of patients is at 6 sigma level. It's the best we've ever done. But if you talk about 30-day mortality, 30-day mortality after surgery has not changed in the past 30 years. And in fact, this is from an article in The Lancet that was published last year, It is the third leading cause of death in the first 30 days after surgery. And 8 million people have an MI every year in the world after surgery. So as much as the system is disjointed, and as much as we think that we are doing better and we need to work together and we have this idealistic approach, we are not there yet. And we do have lots of work to do, especially not in the intraoperative period, but especially, I'm going to say, the preoperative period and the postoperative period, which both of them will lead to a significant adverse outcome after surgery. Now let's talk a little bit about working together. And this is really an excellent article that was published in 2015 at the Journal of Hospital Medicine. And for those of you who are not aware, obviously, hospitalists are an upcoming power. There are 60,000 hospitalists or practicing hospitalists in the United States. So actually, there are right now more hospitalists than anesthesiologists. It's a new coming specialty that did not even exist until, I believe, about 1976, when the editorial of Goldman et al. Was published. This particular task force was put together in 2015 to talk about hospital medicine and perioperative care, and a framework for high quality and high value collaborative care. And some of the individuals on this task force are respected, amazing, smart, collaborative, and so on. In fact, I know many of them, and I have nothing but greatest compliments for them. That said, I have ran a word search in this particular document. And what I have seen is the word anesthesia was mentioned 7 times in this entire document. And out of the 7 times, the word anesthesia care or anesthesiologist was there probably about 2 or 3 times. None of the members of this team was an anesthesiologist. They were hospitalists. And so obviously we can say we want to work together. We can say that we want value collaborative care, but when the authors don't include any anesthesiologists, that's a challenge. And in fact, when you look into one of the tables in that article, you can see what it says about anesthesiology. In the preoperative, in case you didn't know, we conduct airway assessment, review readiness for surgery, and review anesthesia options. While hospital medicine identifies medical issues that affect perioperative care, ensures optimization, and provides anticipatory guidance. Obviously, I have a problem with this. I like to believe that this is the situation in 2015, and the gestalt has moved forward. And the gestalt now is much more that we work together, and that anesthesiologists don't just focus on the intraoperative care and basically relinquish the preoperative or the postoperative care to hospitalists, and that we really need to work together. Now, the question is it really what we need? Do we really need these articles to be published in what specialty says it's better than the other specialty to provide care? I would like to believe that our pro-con was doing better. If you notice, our pro-con has 2 anesthesiologists and 2 hospitalists. Each one really had to present their own arguments. And then we had an editorial that was co-authored by a hospitalist and an anesthesiologist. And I think that the overall theme and the overall language in the pro-con Anesthesia Analgesia and the editorial were much more collaborative than previously. And I just hope that that will just continue. Now, on the right-hand side, we see the Titanic. And why do I show the Titanic? I mean, the left picture is pretty clear, right? The reason is because I always remember the thing about rearranging the chairs on the Titanic. And in this one, it says, deck chair rearrangements, working group, are you ready? Obviously, the Titanic is going down. And so the question is, are we focusing now too much on who is doing what rather than on the overall gestalt, where really changes in perioperative mortality have not changed in the past 30 years? I'm going to close in the next 3 or 4 minutes, but I did want to dive a little bit into why did this happen? Because maybe when we dive into why did this happen, we can understand how to fix it as well. And so we have to look after the money. There is just no two ways about it. It is the reality of life. And I'm going to start on the left-hand side, which is how to get paid in anesthesiology and private practice versus academic medicine. I don't know who is in the audience today. I'm just going to assume that we may have both specialties. In anesthesiology, we are getting paid by time units. I'm sure everybody knows that. There are base units and there are time units. That essentially means that when you are not in the operating room, provide care, you're not getting paid. Now, CMS basically says that the preoperative evaluation is somehow bundled together with the intraoperative units, and that's very nice in theory, but again, in reality, if you're in private practice, it doesn't matter how much time you spend in preoperative area, you're not getting paid for it. All of it is about how many units did you log during the intraoperative period. Academic medicine is a bit more complicated because sometimes it's all going together to a practice group model, and some things are being valued differently. So what does that mean? Well, it means that to me at least, and this is a personal opinion, it does not reflect the opinion of any organization, the specialty of anesthesiology has to some degree lost some of the domains it used to really occupy because of this payment model, right? And by the way, that may be one of the reasons why the perioperative surgical home was not that successful, because the question was, how do you get paid for it? And as we know, there is no void. And when we retreat for some area, other specialties simply just say, well, we need to provide that care. And there comes the hospitalist. And if you are looking at the payment of the hospitalist, obviously they're just getting paid by the hospital. It's that simple. And obviously we do know that anesthesia group also get paid to some degree by hospitals as far as all kinds of supplements. So the bottom line is that the payment model is a challenge. It underlies all of it. I think that we need to work together, but as far as changing the mind and hearts of anesthesiologists about all of this, it may be difficult if the payment model itself is not going to change. So to the question of if the money is not the issue that's going to change our minds right now. So what will change our mind beside providing the best patient care that we can? Well, there has to be a burning platform, which is on the right-hand side. And that came, and I'm sure you know that, from the Northern Sea, where a platform was burning and there was one person who survived. And when he was asked, why did you jump from the water into the water? Because by the way, nobody else jumped and he was saved. He said, my platform is burning. So that's a very famous sentence. And on the left side, you can see the iceberg is melting, which is another interesting business model that talks about change. And it says that people will not change and behaviors will not change unless your iceberg is melting. Is an iceberg melting? This is a slide that is one of the leaders in value-based care. He's at University of Texas in Austin, Kevin Bozak, who is the president-elect of the American Association of Orthopedic Surgeons. And Kevin has presented this in one of our meetings. And basically, these are the challenges that we have. We have unsustainable costs, we have variation in quality, we have lack in coordination. So I'm going to say that we have to think about all of this. We have to think about better patient care, and we have to somehow deal with the payment issue and work together and make sure that patients who need high-level medical optimization have the hospitalist, and patients who do not need that high level can have the anesthesiologist. With that, I'm going to close this very brief presentation. I strongly believe in the concept of team of teams. We do need to move to that direction, but we do have to appreciate why are we doing right now how we're doing, and from that point, move forward. I'm going to stop here and stop my sharing, and Catherine's presentation is going to come first. Again, questions, we'll answer all of them at the end.
Okay, thank you so much for that introduction. I'm going to be talking about perioperative sustainability. And before I get started, I don't have any disclosures except for my NIH award from the National Institute of Aging. And as I talk about this review article that we wrote for the HSR special issue, I want to start by saying that I'm not an expert in perioperative sustainability. There are many other people who have made substantial contributions to our understanding and knowledge in this space. And I did cite many of them in the review article. So what I want to do is just share some of what I learned in the course of writing this review. And one of the goals that I have is just to provide a broad framework for anesthesiologists to understand climate change and our potential to serve as sustainability leaders wherever we may be. So we don't have time to review the entire article. So what I'll do in the next 15 minutes is to give you some background about the relationship between healthcare and climate change, talk about how to categorize greenhouse gas emissions, introduce the triple bottom line framework and stabilization wedges as a conceptual model, and then finish with a call to action. I'm actually going to start by showing you this throwback slide. Many of you may recognize the cover of this report called To Err is Human. This was a landmark report published by the Institute of Medicine in the year 2000, and this galvanized the medical community because experts estimated that as many as 98,000 people died in any given year from medical errors that occurred in hospitals. This was the equivalent to one jumbo jet crashing every single day of the year. And when Zeev asked me to write this review article, one reason I agreed to do it was because I believe that we're in a similar watershed moment for healthcare, with the increasingly widespread recognition of climate change's impact on health. Climate change affects the social and environmental determinants of health, the things that we usually take for granted, including clean air, safe drinking water, sufficient food, and secure shelter. According to the WHO, between 2030 and 2050, climate change is expected to cause approximately 250,000 additional deaths per year from malnutrition, malaria, diarrhea, and heat stress. The direct costs of this climate change-induced damage to our collective health, which doesn't even include adjacent health influencing sectors such as agriculture, water, and sanitation, is estimated to be between $2 to $4 billion per year by 2030. But in addition to recognizing the many impacts of climate change on human health, we also need to recognize that the healthcare industry itself is a major contributor to climate change. Worldwide, the healthcare industry accounts for 4.4% of global net greenhouse gas emissions, which is about 2 gigatons of carbon dioxide equivalents. That is the equivalent of the annual greenhouse gas emissions from 514 coal-fired power plants. The top 10 emitters by country account for 75% of greenhouse gas emissions from the health sector. But if you actually consider the health sector itself as its own independent country, it would be the 5th largest emitter on the planet. So as you can see in this chart, the US is the #1 producer of healthcare-related emissions. Healthcare emissions makes up almost 10% of the total greenhouse gas emissions generated in the United States. And a conservative estimate of the environmental impact caused by the healthcare industry in the US alone equals an annual loss of approximately 400,000 disability-adjusted life years. You can break down the sources of greenhouse gas emissions within the healthcare sector even further. This figure categorizes the World Health Organization's health sectors into the 3 emissions categories defined by the Greenhouse Gas Protocol, which is the world's most widely utilized greenhouse gas accounting standard. Emissions emanating directly from healthcare facilities and healthcare-owned vehicles make up 17% of the sector's worldwide footprint. This is also called Scope 1 or direct emissions. Of particular interest to anesthesiologists, volatile anesthetics such as isoflurane, which is a chlorofluorocarbon or CFC, and sevoflurane and desflurane, which are hydrofluorocarbons, HFCs, as well as nitrous oxide, all fall into this category. Indirect emissions from purchased energy sources such as electricity, steam, cooling, and heating comprise another 12% of emissions, and this is categorized as Scope 2 emissions. The rest of the emissions, about 71%, are grouped as Scope 3 emissions, and these are indirect emissions derived from the healthcare supply chain through the production, transport, and disposal of goods and services, such as pharmaceuticals and other chemicals, food and agricultural products, medical devices, hospital equipment, and instruments. So why should we as anesthesiologists care? Within individual hospitals, the OR generates almost 1/3 of total hospital waste and uses up to 6 times the energy required by the rest of the hospital. Up to 80% of OR waste is generated before the start of the operating room procedure, from opening sterile packaging of instruments and supplies. Of relevance to anesthesiologists, volatile anesthetic gases have been reported in some studies to account for over 50% of greenhouse gas emissions from the OR. This is not only because of the high global warming potential of volatile anesthetic gases and nitrous, of which desflurane is the worst, but also the fact that 95% of inhaled anesthetics is exhaled as waste rather than metabolized by the patient. If I had to choose one thing that every anesthesia practice could do that would have the biggest bang for their buck in decreasing our specialty's climate footprint, it would be to eliminate the use of desflurane as an anesthetic, which we have essentially done at UCSF, despite our historic association with desflurane. And until relatively recently, the healthcare industry has not been as focused on mitigating their greenhouse gas impact the same way other industries have been. So this idea of the triple bottom line, which is sometimes summarized as people, planet, and profit, is a way for organizations to account for the total cost of their business activities, not just in terms of the bottom line of their profit above all else, but also the impact of their activities on the people within the organization and the surrounding community, and also on the planet in terms of the climate impact of their activities. This is sometimes referred to as accounting for the social cost of carbon, the net economic damage to society that results from 1 additional ton of CO2 emissions. This is something that the business community has already embraced, but we in healthcare have only just started paying attention to the triple bottom line. There was a really nice article in the New England Journal of Medicine Catalyst written by Jody Sherman and her colleagues a couple months ago that talks about this need for healthcare organizations to be more like corporations in the area of healthcare sustainability reporting, especially given our outsized impact on climate change. Paying attention to the triple bottom line, as well as advocating for sustainability accounting and reporting, is something that each of us can advocate for at our own institutions. In addition to changing the sustainability culture of healthcare institutions and their willingness to acknowledge and quantify the negative impacts of healthcare on our climate, each of us as individuals can also make a difference. This figure, adapted from Pacola and Sokolo's landmark paper that was published in Science in the year 2004, helps visualize the potential impact of collective efforts to address climate change. You can see along the current path what will happen if we do nothing, compared to the flat path that shows what might happen if we take the necessary steps to reduce carbon emissions. When you break down the stabilization triangle even more into individual stabilization wedges, you can see that each wedge, comprised of things we can each do as individuals and collectively as a society, represents the opportunity to avoid 1 billion tons of carbon emissions per year by the year 2055. The original article described up to 15 categories of wedges of stabilization that could be scaled up to contribute to the stabilization triangle, each of which the authors felt strongly needed to be addressed to avoid doubling emissions in the future. So in our review article, we further adopted the stabilization wedge model for the operating room setting. These wedges don't necessarily represent 1 billion tons of carbon emissions avoided, but the model can still be used as a conceptual tool to understand the carbon emissions trajectory in the operating room, both with and without climate change interventions. The individual waste categories listed within each stabilization wedge comprise actionable items that have the potential to cut carbon emissions from the operating room. These categories include choosing anesthetic gases with lower greenhouse gas impact, such as substituting sevoflurane instead of desflurane or nitrous, or using TIVA rather than volatile anesthetics. We can also minimize waste anesthetic gases by adopting low flow techniques and optimizing gas scavenging systems. Another category where we can affect our climate impact is better sorting of clinical waste from general waste, which basically means not putting general waste into biohazard bags, as well as minimizing the use of single-use devices and encouraging the reprocessing of these devices. We can also work with manufacturers to remove unused items from prepackaged kits and find ways to recycle or reuse items that might normally be thrown away, such as those foam betadine sticks that come with the epidural kits. To this day, I've never used it once. I just take them home for my kids to play with. We can also switch to reusable gowns instead of disposable PPE. And finally, we can address optimizing electricity usage and optimizing HVAC systems, as well as other areas which we didn't have time to talk about in our review article due to space limitations. But I do want you to be aware that these wedge categories are not exhaustive. However, the take-home message here is that addressing carbon emissions on a per wedge basis can lead to a large cumulative environmental impact. The stabilization triangle qualitatively represents the total potential reduction in carbon emissions that can be achieved if all stabilization wedges are addressed. Our review article details each of these potential areas for intervention in the perioperative setting, and I believe that our collective efforts can make a difference in our climate change trajectory. I want to end with a call to action. So I started this talk by showing you the report that put medical errors and patient safety on the map. Anesthesiologists were building a safer health system well before it was recognized as a major contributor to patient morbidity and mortality. This article by David Gaba came out soon after the Institute of Medicine report was published. And in this article, Dr. Gaba reviewed all the ways that anesthesiologists had already been paving the way to creating a safer healthcare system. And how did we do this? Dr. Gaba highlights the importance of institutionalizing patient safety as a topic of professional concern for anesthesiologists. I believe that we're at a tipping point. Environmental sustainability can and should be a topic of professional concern for our specialty. Individual anesthesiologists such as Susan Ryan, Jody Sherman, and others have long recognized the environmental harm posed by anesthetic gases. Given our leadership and expertise in patient safety, hospital operations, systems change, and our ability to innovate, our specialty is uniquely positioned to lead the change that must happen to decrease the harmful impacts on our planet while still being committed to delivering high-quality surgical and anesthetic care. Our review highlights many examples of when doing the right thing for the planet was also better for patients and the bottom line. We should strive to be known as the specialty most closely associated with sustainability, the way we are currently recognized as leaders in patient safety. We also want to encourage more individuals to view environmental sustainability as a valid academic pursuit, not only by focusing on the important work of understanding our climate impact, but also to study ways to sustain behavior change towards greener practices. I hope that everyone watching this webinar will see climate change action as an extension of our calling to protect and advocate for our patients. And while I don't have time to cover all the topics from our review article, I encourage you all to read it for yourself to learn what actions each of us can take to contribute to a more sustainable future. Thank you so much, and I can be reached on Twitter at Dr. Chen MD or via email at catherine.chen@ucsf.edu. Thank you very much.
Thank you all for being here today for our webinar. My name is Alaa Abd-Elsayed, and I'll be presenting about our article published in the Journal of Anesthesia and Analgesia with the title, The Burden of Coronavirus Disease 2019 Related Cases, Hospitalizations, and the Mortality Based on Vaccination Status and the Mandated Mask Use, statewide data from Wisconsin and narrative review of literature. The reason we wanted to do this work is the controversy around the vaccination and mask mandates in different states. So we thought, let us look at the data, let us look at the evidence, and then come up with a conclusion about this topic. I have no conflict of interest related to this presentation. Coronavirus disease 2019 or COVID-19 cases continue to surge in the United States with the emergence of new variants. And this situation is expected to continue for years to come, given the new variants that we explore every few months or every year. Statewide variability and inconsistency in implementing risk mitigation strategies are widespread, particularly in regards to enforcing mask mandates and encouraging the public to become fully vaccinated. It has been probably the talk of the media in the past 2 years since the start of the pandemic, whether people should get vaccinated or not, whether the mask mandate is necessary and helpful or not. So again, we looked into data from the state of Wisconsin, and we did a review of literature to come up with a conclusion on that topic. This was a cross-sectional study conducted on July 31st of 2021, utilizing publicly available data from the Wisconsin Department of Health Services, and data was abstracted on total COVID-19 related cases, hospitalizations, and death in the state of Wisconsin. Our primary objective was to compare the total COVID-19 related cases, hospitalizations, and deaths in vaccinated versus unvaccinated people in the state of Wisconsin over a 31-day period, which was during the month of July 2021. And probably our data in Wisconsin will be very similar to other data in other parts of the country. We also performed a narrative review of the literature on COVID-19 related outcomes based on mask use and vaccination status. Our results probably were, I would say, expected for people who believe in the vaccination and wearing the mask. So in the state of Wisconsin, during July 2021, total COVID-19 cases was 125.4 per 100,000 fully vaccinated people versus 369,000.2 per 100,000 not fully vaccinated people. Very clear that the difference here was statistically significant between both groups. Also, we found that total COVID-19 hospitalizations was 4.9 per 100,000 in fully vaccinated people versus 18.2 per 100,000 in not fully vaccinated people. Again, it was very statistically significant, and the difference is very obvious from the numbers. Total COVID-19 deaths was 0.1 per 100,000 fully vaccinated people versus 1.1 per 100,000 not fully vaccinated people. And again, the number here is very clear, big difference between mortality in vaccinated and unvaccinated people. And again, the difference was statistically significant. This is a graph to summarize our results. If we look at the first graph here, again, blue is fully vaccinated people, red is not fully vaccinated people. So this was 0.1 again per 100,000 in fully vaccinated people against 1.1 in not fully vaccinated people. So that represents 11-fold increase of possible mortality if people did not get the vaccine. Hospitalization was 18.2 per 100,000 in not fully vaccinated as compared to only 4.9 in 100,000 in fully vaccinated people. That's almost 4 times higher to be hospitalized if you did not get the vaccine. And when it came to the number of cases, again, was statistically significant, about 4 times higher detection of cases in people who are not fully vaccinated. Narrative review of the literature also demonstrated high vaccine effectiveness against COVID-19. Infection prevention was 79 to 100% among fully vaccinated people, and COVID-19 related hospitalization was 87 to 98% among fully vaccinated people. And all COVID-19 related, this was 96.7 to 98%, again, protection among fully vaccinated people. Those 3 results of, again, like infection prevention, hospitalization, and related death show very well that the vaccine has been very effective in preventing the 3, which was very similar to the data we retrieved from Wisconsin. Studies have also generally reported that mask use was associated with increased effectiveness in preventing COVID-19 infection. And that was a very important variable because of all the controversy around mandating masks, wearing masks or not wearing masks. And when we summarized the literature, there have been a few studies that showed there is increased infection among people who are wearing the mask, but the vast majority of studies with good methodology showed that actually the mask was protective against the spread of COVID-19 infection. The conclusion of our study was a strict adherence to public mask use and fully vaccinated status are associated with improved COVID-19 related outcomes and can mitigate the spread, morbidity, and the mortality of COVID-19. Anesthesiologists and intensivists should adhere to evidence-based guidelines in their approach and management of patients to help mitigate spread. And again, these results are very consistent all across the country in majority of literature that vaccination and masks are protective against the COVID-19. This has been proven by data, proven by science, and it's our role, and I'm glad that we had this opportunity to do this webinar to spread the word and the knowledge based on science and not based on any other false information people may obtain from social media or other media forums. Again, let us follow the science, let us spread science, and let us do more studies and follow the evidence-based medicine. Thank you, and I really appreciate the opportunity that I had today to present our article and our research to all of you. I would like to thank you all for attending our webinar, and I'll be happy to take any questions.
We are back. I'm asking for the panelists who are there. Here you are, Catherine. So you're there. Hi, Alaa. Great presentations to both of you. I have some questions of my own, of course, but before we do that, I'm asking the audience to send us any questions you may have. And I have a couple of questions already. And so we started with a question by Dr. Ellis, John Ellis. And I'm just going to read his text. It says, even if the 30-day perioperative mortality increased, doesn't this reflect improvement given sicker, older patients undergoing surgery today, or not, giving them less invasive procedures? I think it's very insightful, John, and you're right. Number one, it didn't increase. The rate is stubbornly the same. It just has not changed. Some of the analyses that have been conducted, such as the one in the Lancet that I'm recommending to read, did adjust for surgical case mix. And so from that perspective, I can say that it is not probably a result of that particular variable. Can we talk about other confounding variables? Maybe we can. But I'm going to say that if you look at the reasons behind this mortality, a lot of them are because of postoperative MI and cardiac events. A lot are connected to intraoperative hypotension, for example, and some other variables. And so I stand by what I believe from reviewing the literature, which is we have done a lot in the intraoperative But intraoperative is actually easier because you have one group that controls everything with very strict protocols. I think the perioperative is more complicated. You have the preoperative, you optimize patients. You have the postoperative, where you talk about hands off to the physicians in the community. And so we probably have not done as much progress there as we want to. My fellow panelists, any comments about that, please?
I think John's question is a good one, and I agree that there's more and more older adults undergoing procedures that are higher risk than they had been in the past. And so I think we're increasingly recognizing that frailty and other issues that affect older adults are something that we as anesthesiologists also have to be concerned with during the perioperative period.
Yes, I agree also with Kanda. I think you presented it very well, Zeev. And I think as we do our research overall, I think there will be some confounders that we need to work on in the future. Not easy, as you know, confounders are not easy to always capture. But like this is definitely the age and how sicker the patients get. I think we will see more change in outcomes, and we have to adjust for confounders as we do our studies.
Yeah, I agree. And on the other hand, we have to remember the second part of what John said, which is there are also less invasive procedures now. So it's kind of complicated. It's a two-edged sword, but it's certainly something to keep in mind. Alaa, I had a question for you, and it's not political, but semi-political. I mean, there's so much craziness going on right now. And, you know, the data you have showed us is, I'm going to call it the old COVID-19. Mm-hmm. And at least my understanding is that the current variant is somewhat different than the variant you have done your research on. How do you think that changes your conclusions, or does it at all?
Yeah, that's a very good question, Zeev. When we submitted this article, it was, in the midst of probably Delta variant. But overall, I think there will be more variant as we go. This is not going to stop. We'll have one variant after another. And while the results of our work may change in that maybe mortality will be lower because hopefully new variants are milder and not fatal. But we see in some countries there are still increase in hospitalizations, increase in people getting sick. Again, vulnerable people, immunocompromised people. So I think sometimes following the same concept, I would say, I have kids. And I always tell kind of people in the closed places, okay, I understand we're all vaccinated, but the kids may not. So why don't we put on our masks? Sometimes it's more of, we need to think about this as a public health problem. It's not about a personal problem or like me got the vaccine, I'm safe. I got the infection before. I think we need to think of each other and of the vulnerable population, immunocompromised beloved ones. So this way, even with them, so I think with the mild variant, if we don't take them seriously when they happen, we probably will see still maybe less mortality, but with less hospitalizations. But again, it could be the beloved one for somebody.
Yeah. Complicated. Catherine?
Yeah, no, I agree. I have young children, and one of them still not vaccinated. So it's a little bit personal for me as well. And it's hard to kind of see the mask mandates lifted, but I understand that there's a balance between personal freedom and government mandates. So we're masking still as a family, still trying to be socially distant, right. But that's the personal choice that we're making as well.
No, and I agree, and I actually didn't even want to go to the direction of personal freedom versus China as an example. My point was more about, and it's a difficult question, at what point do we stop calling it a pandemic and moving into epidemic? We have every year epidemic of the influenza, and every year people die, and so it's a tough question. I don't have an answer. I'm just saying it's hard to know when to make the switch, and it's a no-win situation. It doesn't matter when you'll make the switch. Some people say you're wrong. Some people say you're too early. Some people say you're too late, and that's just about it. Catherine, why do you think that progress is slow when you talk about perioperative sustainability. I mean, I remember having an ASA task force about it 15 years ago. And if I look at the activities of the ASA today, there are probably less activities today than I remember 15 years ago. So why do you think it's so difficult to move forward?
That's a really good question. And I think that's something that I'm just interested in general is like, how do you actually get people to care about something and change behavior when the evidence is already there that climate change is harming health and healthcare is also harming the climate. I remember as a medical student also probably around 15 years ago, was working with a surgeon and we were talking about greening the ORs back then and talked about writing a review article back then. I didn't get around to it. So this is kind of, you know, closing the loop. And nice that I was able to focus on this topic, but I really do think it's hard to make it like take ownership of an issue that's so big and so out there. I think everybody knows that climate change is an issue, but it's like, what can we as individuals do and what difference will we actually make given the breadth of the problem? But I think if we each kind of look at that Wedge's model as every little step that we take will make a difference and collectively it adds up over time, all the individual efforts that we make. I think that's motivating, at least for me, enough that I've started changing some of my behaviors where I don't really use any nitrous anymore, whereas I used to be willing to do a quick nitrous wake up. I don't use desflurane because we don't really have access to that anymore at UCSF. And then with regards to separating my clinical waste versus general waste, I used to just throw things in the red trash bin without thinking about it. But the vast majority of things that we work with, like it's not clinical waste. We can just put it in the regular trash bin. So I'm very conscientious of where I'm eliminating the trash that I generate also.
Yeah, these are good points. Alaa, I have a question for you from Dr. Longnecker. He says the science is clear, but the problem is application of the science, i.e. the use of masks by the public. What are the successful approaches that changes public behavior? Thank you.
Yeah, that's a good question. If we keep it outside politics,
yes.
Probably that's why I think it's important to publish and provide evidence rather than personal views or political views. And I think that's we will all agree. I mean, it's public. I guess we can speak that we did not really, I would say, do it scientifically 100% because when we started talking about the mask, let us look about our regular practice before the pandemic. If I'm taking my kids to the pediatrician, they are coughing, they will handle them a mask at the door. If somebody is entering the hospital coughing or have cold-like symptoms or flu-like symptoms, we will handle them a mask at the door. That's normal. That's been routine before the pandemic. That's how we always done it. So I think focusing on science, I think that's the key. Like focusing on science and what the science said is that what we should follow and try not to get biased by other views or personal views because people will always disagree on things.
Yep, that makes sense. Catherine, I know that you answered that question, but I think it may be worthwhile discussing it. The question for Catherine was, how do you see nitrous oxides comparing with other fluorinated inhalation anesthetic agent with respect to environmental outcomes? Concerns, sorry.
Yeah, so I was surprised when I was doing this review that nitrous is actually not as bad as desflurane, but it still lasts in the atmosphere for about over 100 years. I think the specific number is 117, but don't quote me on that exact number. But it also has about 260 times the global warming potential of carbon dioxide. So it's still harmful to the, in terms of its climate change impact. And worth noting, because I know we use it a lot, at least at UCSF, we use it a lot on labor and delivery. And I think dentist's office are another place where nitrous is very commonly used. I actually try to tell my dentist not to use the nitrous. I make my kids get their local injection if they're getting their cavities filled. Just again, like small changes that I've made in my behavior in response to this information.
That's interesting. I can tell in pediatric anesthesia, there are two schools of thoughts now. Some of them just start an induction with oxygen nitrous oxide and switching to sevoflurane. But some are just starting straight with sevoflurane and stop using nitrous oxide altogether. because of all these effects that have. Alaa, any insights about that?
No, I agree actually with you and Catherine. A lot of those practices, particularly in sustainability, will require, I think it's like a lifestyle change when you talk about your diet or exercising. Really, people need to get into extensive programs, keep teaching people and basically educating them on a lifestyle change on how we practice anesthesia and how to avoid the harmful gases. Hopefully one day, maybe, you know, like if you need the nitrous oxide, you need to call the technician to get it to you. Sort of more try to limit the use and encourage people to have more better kind of environmental friendly practices.
Absolutely. I don't see any other questions. So any last concluding words from any of the two of you?
I can start. I do think that there's a lot that we as individuals can do in the OR just with regards to our own practice. I mentioned the avoiding desflurane nitrous. I just looked it up and it looks like sevoflurane only lasts a year in the atmosphere. So that's really in contrast to nitrous, and even desflurane is only about 3 years in the atmosphere. So that's a big reason why I stopped using nitrous. And I also think that we have an opportunity because we're hospital-based. We can, initiate changes at our own institutions, and whether they be quality improvement projects or actual like pursuing research approaches to studying behavior change and changing our practices. I think this is an opportunity for anesthesiologists to really make a difference with regards to our future climate impact.
I think an article pro-con for nitrous revisited.
For sure.
After, I don't know, 50 years or 100 years of it. Actually, it's more than 100 years, but it's neither here nor there.
Yeah,
Alaa?
no, I do know. Oh, I wanted to say one more thing, because I think
please.
at all the UC campuses right now, I know Seema Gandhi, one of my colleagues, has really been taking the lead in trying to remove nitrous oxide from common use as well on the UC campuses.
Yeah, So I know I would like to end the first by thanking you, Zeev, for all the great work you do in the journal. I've dealt with you. I've been editor and I've been submitting my articles. I mean, fantastic job getting the high quality articles published and highlight them. Thank you to everybody who worked on this webinar and make it, again, education is a thing really we can do, generating the evidence through the journal, doing webinar teaching. And I hope over time, those articles and webinars and evidence will be in the hand of decision makers who can maybe start actually making the implementation to change a practice. So again, thanks so much, Zeev. I mean, like you've been doing a fantastic job with the journal.
Oh, thank you. Thank you. And thank Catherine for being an associate editor. I agree with everything you said, Alaa. One of the challenges we have, and I've highlighted in a separate editorial, is the whole concept that's called knowledge translation, which is how do you take knowledge and actually move it to practice? And I really like what Catherine just said about nitrous oxide. Now let's think about it for a second. How many anesthesiologists do you really think know about nitrous oxide as far as sustainability and how long it lasts? I will submit to you that a lot don't. And so that's a perfect example of knowledge translation, of how the cutting edge of science can bring up new and innovative things, but our general community is just slower to adopt them. And if we can move it forward, that's better. There are the different models for it. One of them obviously is a leading journal, such as Anesthesia Analgesia, and articles. I don't know. Sometimes I feel a bit disheartened because we have been doing it for a long time, some of us, and it's almost like a circle. You are publishing on it, and then people are on it, and then 10 years later, everybody forgot what you said 10 years earlier. So maybe it's time to think about some new models. I'm not sure exactly what they are, but I'm putting out the challenge to the younger individuals in the group to think about some new educational models that maybe can hardwire things like the issue of nitrous oxide and masking, rather than just having a great article, a great webinar, and then forgetting about it. That's one of the challenges. And with that, thank you so much for the editorial staff of ANA. Dan and all his crew have been working with me throughout the past year. They have been working day and night, and I really appreciate all their hard work for everything we do and this particular webinar. So everybody have a wonderful day. Thank you for the panelists again. Thank you for the editorial staff, and have a nice day, everyone.
Thank you. Bye.
Thank you all. Thank you, Zeev.